Imagine, just for a second, putting your finger on a patient's pulse and closing your eyes. Most arrhythmias out there, whether they're racing fast or painfully slow, still have some sort of underlying pattern that your fingers can eventually learn to predict. But what happens when there's absolutely no pattern? What if that pulse is genuinely, mathematically unpredictable from beat to beat? Well, that irregularity isn't just a quirky side effect of the diagnosis. It literally is the entire diagnosis. Welcome to The Explainer. Today, we're tearing down and rebuilding our understanding of atrial fibrillation from first principles. Why spend a whole session on just this one arrhythmia? Because the entire management framework for AF has been completely overhauled in the last couple of years. I mean, from how we score stroke risk to which exact treatments we reach for first, the whole paradigm has shifted. If your mental model of AF management is even a few years old, parts of it are absolutely out of date. So we're going to rebuild that model today, right from the ground up. Here is our roadmap for today. We'll start with the mechanism of the chaos, move right into the causes and the matched mnemonic, rethink stroke risk, walk through the AF care pathway, and wrap up with modern rhythm control. Section 1. Mechanism of the chaos. Why there is no pattern. Think about the stark contrast here. Your normal cardiac rhythm relies on this beautiful single-dominant pacemaker, the sinoatrial node, organizing a perfectly coordinated atrial contraction. Atrial fibrillation, it completely hijacks that. Instead of one clear signal, you get chaotic, totally disorganized electrical activity just sweeping through the atria. We're talking hundreds of tiny micro-reentrant circuits and ectopic foci firing off all at the exact same time. And because the atria are essentially just quivering instead of giving a good solid squeeze, this electrical chaos completely abolishes the normal atrial kick that usually tops off the ventricles right before they pump. The direct result of all that quivering is that the AV node, the gatekeeper, is just constantly bombarded by this disorganized static. It ends up only letting a random, totally unpredictable subset of those impulses through to the ventricles. That right there is exactly why the ventricular rhythm itself becomes irregularly irregular. It is the absolute defining bedside finding. It's also why the intensity of the first heart sound actually varies from beat to beat, because the ventricular filling time is changing with every single pump. Okay, so how do we actually confirm this at the bedside? Well, an irregularly irregular pulse is your first big clue, right? But frequent ventricular ectopic beats can actually mimic it pretty closely. So here's a really fantastic clinical pearl. Use the exercise test. Just ask the patient to exercise briefly. Ventricular ectopics will characteristically suppress, or at least drop in frequency, thanks to that exercise-induced sympathetic drive. Atrial fibrillation? It absolutely does not. It's a beautifully simple, elegant test that is definitely worth knowing cold before you grab that ECG to look for absent P waves. Section 2. Causes and matches. Identifying triggers. So rather than just brute forcing a random list of causes into your memory, let's categorize them by what they actually do to the atria, using the incredibly handy matched mnemonic. M is for mitral stenosis, causing structural stretch. A is for alcohol, which is a genuinely reversible toxic trigger. T is for thyrotoxicosis. Always we're screening for that metabolic trigger. C is coronary artery disease. H stands for hypertension, which chronically drives up atrial pressure over time. And S is sleep apnea, specifically obstructive sleep apnea, which is getting a ton of recognition lately as a massive, modifiable contributor. MATCH covers the vast majority of cases you're ever going to see. Now, when we classify these cases, the current framework still looks at duration and pattern. Take paroxysmal AF, for example. That's defined as AF that stops on its own or with intervention within 7 days of onset. But, there's a huge modern shift happening in how we think about this. We're moving away from viewing AF as these rigid, fixed buckets and much more as a progressive continuum. The reality is, it tends to march forward from paroxysmal toward persistent over time as the atria literally remodel themselves. And honestly, that's exactly why stepping in early is quickly becoming the absolute go-to strategy. Section 3, Rethinking Stroke Risk, the new framework. Here's the scary part. The primary danger of AFib isn't actually the funky rhythm itself. The real danger is that a quivering, non-contracting atrium creates a pool of stagnant blood, especially tucked away inside the left atrial appendage. It's literally the perfect breeding ground for a thrombus to form, and if that clot breaks loose and takes a ride up to the cerebral circulation, well, that is precisely how AFib causes a devastating stroke. Because that stroke risk is so severe, the way we stratify it has genuinely changed. The old familiar CH2DS2 VASC score?
It's been superseded by the much more streamlined CH2DS2-VACE score. You might notice something missing at the end there. Female sex has been completely dropped as an independent risk modifier. This is a major update, and it reflects a mountain of evidence showing that female sex alone, without other risk factors, just doesn't meaningfully increase thromboembolic risk.
So how do we use this new score in practice? Current guidance is super clear. A score of 2 or more, that is a hard Class 1 indication for anticoagulation. It's mandated. But here's the kicker. A score of 1 still carries a Class 2A recommendation. That means you should be actively considering anticoagulation for a score of 1, not just brushing it off or deferring it by default.
Of course, on the flip side, we're still using the Hasblood score to assess bleeding risk, where anything over a 3 flags a patient as high risk. But listen very carefully to this paradigm shift. A high Hasblood score is a red flag to address modifiable bleeding risks and to watch the patient closely. It is absolutely not an excuse to withhold life-saving stroke prevention if their risk score warrants it. Oh, and by the way, tossing antiplatelet therapy on top of anticoagulation purely to prevent strokes? Yeah, that's no longer recommended. The bleeding risk just completely outweighs any added protection.
Section 4, the AF care pathway, the whole patient approach. This updated pathway breaks everything down into 4 super neat, actionable pillars. C is for comorbidity and risk factor management. A stands for avoid stroke and thromboembolism. R is to reduce symptoms, that's your rate and rhythm control, and E is for evaluation and dynamic reassessment. The whole point of this AFCAI care framework is to give you a comprehensive roadmap to treat the whole patient, not just stare at the ECG rhythm. And baked right into that evaluation pillar is a brand new universal baseline. A transthoracic echocardiogram is now recommended for essentially every single newly diagnosed AF patient. Getting a look at the heart's actual structure is now an absolutely essential first step to guide this entire whole patient game plan.
Section 5, modern rhythm control. This is the biggest shift.
Prepare yourself, because the 2024 ESC and EACTS guidelines just dropped a massive update. Catheter ablation is now officially recommended as a first-line rhythm control option for suitable patients with paroxysmal AF. No more waiting around. It is no longer just a second-line fallback for when antiarrhythmic drugs fail. The safety and efficacy data have gotten so incredibly good that ablation just skipped right to the front of the line. Just remember, though, any patient getting an ablation needs oral anticoagulation for at least 2 months afterward, no matter what their risk score is, because the procedure itself causes a temporary spike in clot risk. And if we're talking about cardioversion, the current guidance has gotten noticeably more cautious. The threshold for considering an AF episode recent enough to just go ahead and cardiovert without checking for a clot first has shrunk. The old rule was 48 hours. The new safety window is a strict 24 hours. So even very brief episodes now need you to consider short-term anticoagulation cover. And honestly, taking a wait-and-see approach to see if they convert spontaneously is now explicitly favored over rushing in to shock them early. But if you take nothing else away, let it be this massive conceptual shift. You absolutely must treat the substrate. The reality is that AF recurrence and progression are directly fueled by those unaddressed comorbidities we talked about. Going aggressively after blood pressure, screening for sleep apnea, managing weight, and locking down blood sugar, that is core AF management now. It's not just a nice-to-have side quest. We have to treat AF as the downstream result of a much larger cardiometabolic fire. All right, let's pull all these threads together. We started at the cellular chaos that completely wipes out the atrial kick, walked through the MATS triggers, and updated to the streamlined CH2DS2VA stroke risk score. We mapped out the whole patient AF care pathway, and we finished with that huge pivot toward first-line catheter ablation. And that is atrial fibrillation, truly rebuilt from first principles. So, the very next time your fingers feel that unmistakably chaotic, unpredictable pulse, are you ready to apply this new mental model? If you found this breakdown valuable, please support the explainer, give it a like, comment your thoughts down below, ask any questions you might have, and hey, suggest some future topics you'd love to see us tackle. And of course, absolutely make sure to subscribe for more deep dives. Thank you so much for joining me today, and I'll catch you in the next one.